Good day, gentlemen. This week we got a great victory from Richard, aged 61, who had a PSA of 9, got on the protocols, and in 30 days his PSA is down to 3.4. Congratulations to you, Richard. You listened, and now just maintaining control. Of course, mine went from 8 to 48 in 6 months back in 2011. And I was able to keep it under control, going on 15 years now. My last PSA last week was just 1.9. And you can do it as well. Anyway, I've got a real neat video for you to watch. Stay tuned, just hang on and click and subscribe as you keep in tune with all the videos I'm going to be producing. And stay strong. Enjoy the video.
Get a lot of questions from all over the world regarding this, and so we're going to start off with the basis of what an MRI is. I think a lot of people tend to be familiar with the term, but they don't know exactly what it does and the scope of what the MRI covers when it comes to the prostate.
Well, MRIs are used for the whole body, but they got repurposed for prostate imaging 10 years ago. It was always hard for MRIs to delineate the tumor as opposed to the prostate gland itself, because prostate cancer being a low-grade tumor, it's very similar to prostate tissue. And so there were some new techniques that were developed to finally help the tumor light up more in the background of the prostate. This obviously is very revolutionary technology when it first came out. We have sort of jumped in with both feet once the studies showed that in head-to-head trials that MRIs were even better than biopsies in finding cancer. We abandoned random biopsies at that point and use MRIs to find the tumor and then do targeted biopsies to confirm or refute if the abnormality seen on the MRI is a high-grade lesion that needs attention.
So when it comes to the MRI itself and lymph nodes, for instance, does it only see pelvic lymph nodes when they're doing a prostate MRI, or do they see abdominal lymph nodes? How far are they covering in the body?
It's not even the whole pelvis. When you do an MRI of the prostate, it's really focused on the prostate itself. There's some surrounding area in the pelvic area picked up on the MRI, and they may see an enlarged lymph node. But MRIs, CAT scans, and the like are not that great at finding early-stage cancer spreading to the lymph nodes. That's for PSMA PET scans or Axemin PET scans, choline PET scans. The problem being is that the tumor in the lymph node has to be big enough so that the lymph node starts to swell up. And that's a more advanced stage of cancer in the lymph nodes, whereas these PET scans can detect smaller amounts.
So when we talk about MRIs, we have the images that are taken, but we also have the people reading the images. And I think a lot of times patients are wondering, how accurate is that? Do they need to go to a center of excellence to make sure they're getting a quality MRI and a quality person reading the images? Does there need to be a second overread to make sure that it's accurate in its reporting?
It is tricky to read MRIs in an optimal way. One expert told me it takes 500 to 1,000 practice reads to be really proficient. In cases where people are having MRIs done at unknown facilities where the reputation is not clear, or perhaps they don't have a large volume of prostate MRIs, you can have the images stored on a disk and sent to a center of reference. On the West Coast, we use UCLA often. On the East Coast, we send patients to Cornell. In New York, what the doctors who have experience reading these will say, they'll look not only interpret the images, but they'll also look at the image quality and tell you if the MRI that was used is generating images that are good enough to interpret. And if they are, then they can overread it and provide confidence that the readout is accurate. Problems with people making mistakes on MRIs at garden variety centers around the country, it's a real issue, and double checking is often a very prudent thing to do.
How often does an MRI have the possibility of missing a significant cancer?
So well-performed MRIs read by experts can probably miss small significant cancers in about 10% of people. Significant means that if you did a biopsy, that it would have a Gleason score of above 3+3, and significant in a clinical sense, it may be something different, because small, higher grade lesions are still very low propensity for metastasis. And significance in the cancer world, including the prostate cancer world, has to do with whether or not it has or will spread. One way to circumvent this limitation with missing 10% of significant cancers is to ensure that people get annual screening, because the ones that are going to be consequential will over time will grow and at some point become detectable, in my opinion, almost always before they metastasize, still while they're treatable and curable.
So when you say annual screening, are we talking about PSA and MRI together?
Screening is perhaps not the right word. Screening is where people are otherwise healthy and they're going in to check and see if there's something brewing. Annual follow-up of someone that's had screening, let's say someone had an MRI and his PSA is running high, the idea of doing an MRI and saying, it's clear, we're done, is probably a little bit cavalier. In fact, many doctors will then go on and do other testing with OPCO or ExoDx, or they'll go on and do a random biopsy, just to be sure. But I think that kind of defeats our purpose of trying to circumvent these random biopsies, which are kind of unpleasant. Annual checkups after having had an MRI that is normal is a prudent thing to do, especially if someone's running a high PSA. That's probably the reason that they've had an MRI, is because their PSA is on the high side. And yes, in those individuals, we would continue to check the PSA probably every 6 months and use that information as well to decide what next steps would be appropriate.
When we talk about PSMAs, we always say that, you can see prostate cancer after 0.5. Is there a, certain situation with PSA and MRIs where you're definitely going to, see cancer tumors on the prostate if the PSA is over a certain threshold?
Well, in men that still have their prostates, PSMAs came on the scene to try and help people that have had a radical prostatectomy. Now their PSA is rising. Where is the cancer located? But PSMA PET scans are also good for staging newly diagnosed people, and they can be a consideration to circumvent doing a random biopsy in people that have an elevated PSA, undergo an MRI, and then a suspicious lesion is detected. Those individuals could consider doing a PSMA PET scan to see if that lesion lights up, because the PSMA PET scan is disease specific. Presumably, if the PSMA PET scan doesn't light up in that area, then that shadow that was detected on MRI isn't consequential prostate cancer.
So this kind of begs the question, and I see this oftentimes in the comments section, and even just talking to patients, they're wondering, why would you just not get a PSMA scan first? What is the benefit of getting an MRI first?
MRI is a little bit more precise inside the prostate than PSMA. MRI doesn't have any radiation exposure. MRI is covered by insurance, whereas PSMA is only covered in men who have been diagnosed with prostate cancer, and it's expensive, $5,000, something in that range. So there's a lot of reasons that we don't screen with PSMA. I would say if it was covered by insurance, we'd still be reluctant to do something that exposes people to radiation when we have a MRI scan that doesn't incur any radiation whatsoever.
When someone gets an MRI, are we seeing the entire prostate? Are we seeing the front side, the back side? Is there anything that is missed that, we kind of have in question?
No, that's of course one of the advantages of MRIs over random biopsies. Random biopsies typically sample the posterior half of the prostate, which is next to the rectum. It's not a bad area to sample because that's where 90% of the cancers occur. They will miss the front of the prostate, and MRIs don't. MRIs see the whole gland. It's part of the reason in head-to-head studies they've been shown to be more accurate than random biopsies.
And are MRIs pretty accurate in detecting seminal vesicle invasion and anything that where the cancer is leaking outside of the prostate?
Seminal vesicle invasion, yes, quite accurate. Extracapsular extension, which is talked about a lot in the reports, and it's very much on the surgeon's mind because he then has to be concerned when cutting the prostate out to leave extra space, and that may make it more difficult to do nerve-sparing surgery. So they're always leaning over the radiologist's shoulder. Is there extracapsular extension? And patients tend to also wonder, because you'll see in the reports that the doctor will say there is or there isn't, or maybe there is or maybe there isn't. And patients are often wondering if this somehow relates to a worse form of cancer. It sounds much worse, spreading out the edge of the prostate, more aggressive. It doesn't create problems for treating with radiation because they can just spray over the edge of the gland a little bit wider and achieve better cure rates. So extracapsular extension often is something people pay a lot of attention to in reading these MRI reports, and I'm sure it's relevant for patients who are thinking about doing surgery. I'm not a fan of surgery, so in my day-to-day world, it doesn't play a very big role.
Thank you so much.
Management of prostate cancer that has spread beyond the capsule is a difficult problem. Innovative and non-toxic approaches to the disease are urgently required. Recently, a commercially available herbal mixture called PCSPS showed potent anti-tumor activities on a variety of malignant cells in vitro The conclusions are PCSPS inhibits clonal proliferation of human prostate cancer cells, both in vitro and in vivo. Using a murine model, PCS is an 8-herbal mixture which has activity against prostate cancer cells and can reduce the serum level of prostate-specific antigen, PSA, in more than 80% of individuals with prostate cancer. We conducted this study to begin to clarify the molecular mechanism by which PCSPS inhibited the growth of prostate cancer cells. Evidence has emerged that PCSPS is an effective modality that alleviates some symptoms in advanced prostate cancer in a significant proportion of patients, including the cases that failed conventional therapy. This evidence, as well as published data that show the effects of PCSPS in suppressing growth of prostate cancer in animal model studies, is reviewed together with the available data on the possible side effects of PCSPS. The review also covers in vitro studies that reveal the cell cycle specificity, induction of apoptosis, effects on androgen receptor, and other molecular and metabolic changes induced by PCSPS that may explain its anti-cancer activity. Individual chemical components that are present in herbs of which PCSPS is composed, known to have anti-proliferative, anti-tumor, anti-mutagenic, analgesic, and/or differentiation-inducing activity, are listed and discussed. The effectiveness of PCSPS in prostate cancer is explained as due to its complex composition, which may target many signal transduction and metabolic pathways simultaneously, thereby eliminating the backup or redundant mechanisms that otherwise promote cell survival when single target agents are used.